Okay, I think we have most people are on now. So big welcome to tonight's free webinar with Lisa Ferentz. And just to say, tonight's free webinar is a prelude to Lisa's webinar on the 9th of September, which is a trauma-informed approach to assessment and treatment. And just to say, anybody that's interested in attending that webinar, we're doing a special offer tonight. So if you book in the next 24 hours, you'll get 20% off. And Mary, could you please put the discount coupon and the link in the chat? And if anybody's interested, we'd advise to book as soon as you can. We'll just a big welcome, Lisa. And it's really kind of nice to see you again. Lisa and I were just kind of reminiscing. Lisa came to Ireland first in 2017. And you did an event in the International Hotel in Cork. And one of the things I remember about it, I think at the time you were after writing a few books, and people really loved your books because it was the first event that I think we bought maybe about 200 books. And we actually sold every book. So there was no book left. And then you came back in 2018 to Kerry, which was super. I think you did an event that was kind of related to addiction.
Correct. Yes.
So hopefully, you know, when things kind of settle down a bit, you'll make the journey across again.
I really look forward to it. I look forward to it. I have nothing but the warmest memories about being there. So, and thank you, Liam, for making it possible for me to be there in this way, right? We have technology working in our favor. So I am delighted to be with all of you. I'm sorry it's not in person. I miss your, I don't know if you call it brown bread or black bread.
Brown bread.
That's a particular memory that has lingered because that was quite spectacular. Really, along with the warmth of all of the clinicians whom I had the great privilege of interacting with. So I do have a very special warm place in my heart for those of you in Ireland and other nearby places. So thank you, Liam, for the invitation. I'm delighted to be with you all.
Super. Well, I just call out some practicalities before we get going.
Sure.
2 or 3 minutes. Just basically around tech. And if anybody has any tech problems, what we suggest is that you log off and log back on using the link provided. And if the issues persist, Mary is very kindly at the end of the email, and Mary's email is mary@pcpsi.ie. And for the Q&A, I know I was talking briefly to Lisa about the Q&A, and we usually do it in 2 ways. Some people like to come on live and ask questions, Lisa, and we'd really encourage that. And for anybody that would like to do that process, what you need to do on the bottom right-hand side of the screen, as I look at the screen, there's a reaction button. So under that, there's a yellow hand function. So you press the yellow hand function, I'll call out your name, and then all we need you to do is turn on your video and turn on your mic. But again, some people don't like to come on live, so feel free to send your questions in through the Q&A function, which again is at the bottom of the screen on the right-hand side as I look at it. And just before we get going, just a big thank you to Robert and Mary, who are in the background, keeping the show on the road. So a big thank you to you guys. Okay, Lisa, I'm really looking forward tonight because it feels to me that trauma-informed is really the kind of new buzzword.
Yes.
And I'm really kind of looking forward to seeing, you know, what your take on what it means, because it's getting really popular here in different contexts, especially in the context of addiction. So really excited about tonight. So whenever you're ready, you can take
Great.
over.
Thank you. You know, I'm really glad to hear that the phrase trauma-informed care has caught on in your country. It has been a phrase that's been thrown around in the mental health field, at least in the United States, probably for like 6 or 7 years now. And on the one hand, I think it's critically important that we get reminded of the absolute necessity of looking at our clients through a trauma-informed lens. When we do that, I think so much of what they present in terms of their thoughts, their behavioral choices, their emotional lability, and their emotional states starts to make more sense when we can start to look at people through that lens. I want to tell you a little bit about myself and the work that I do. I'm going to tell you a little bit about what inspired me to create this particular training, the training I'm going to be giving in September, as Leah mentioned. I'm going to share with you what I would love for you to be able to get out of that training. So I'll just give you a little sort of coming attraction of some of the content. And then more than happy to answer questions. I'm okay not waiting until the end for the Q&A. So if you've got a burning question, feel free to weigh in sooner. I want this to be kind of spontaneous and natural. And I know what it feels like to have a burning question and then to be told to wait half an hour to ask it. You can't really focus on anything else. So please feel free throughout the hour that we're going to share together to ask any questions or make any comments as well. I'm always very open to learning from you. So I like this to be as interactive as possible. So just very, very briefly, just so you have some sense of who I am, for those of you who are not familiar with my work, I've been in private practice as a trauma specialist now for about 39 years. So it's been a long time. And I think with that, I have sort of the ability to look at the trajectory of how we've been approaching trauma treatment over these last 39 years. I will tell you that I think there have been very dramatic shifts in the way we view trauma and the way we treat it. And I think that by and large, those shifts have been incredibly positive. And they've really helped to not only move the work forward, but I would say that they've also helped to produce a much more authentic and genuine, sustainable kind of healing for our clients than some of the earlier ways in which we were dealing with trauma back in the early 80s, the 90s, and even the beginning of 2000, where I think inadvertently, we were actually re-traumatizing a lot of the folks that we were working with, because the core belief then was that clients, in order to heal, really needed to relive much of what had happened to them. That was by and large the overarching view, regardless of the paradigm that you brought to the work. The belief was that they have to kind of relive those experiences. You were obviously the compassionate witness to that, but what I think we were not paying enough attention to was the fact that we were also inadvertently and simultaneously creating a lot of dysregulation and emotional overwhelm. And a lot of us back in the 80s who were doing this work, used to say that we had these sort of invisible revolving doors from our private practice offices and even from mental health agencies and community agencies, from that psychotherapy place to hospital settings, because unfortunately, we were often doing more harm than good in terms of having people simply relive their trauma without there really being a lot of repair. So when we do think about trauma-informed care, I think that's a critical distinction, that we want to think about doing the work in a way that's reparative rather than simply re-traumatizing. So I've had the privilege of started out working with very young kids, then moved to working with teenagers. Now I work predominantly with people probably in their early 20s, and my oldest client is 80. And I remember when I first started out in the field, a professor said, as you age as a therapist, your practice will age with you. And I didn't fully believe it or understand it, but actually he was right, and it's true. And I have colleagues who corroborate that they're having similar experiences. So I started out working with very young kids. And then, as I say, now it's usually about 20 and above. And when you say that you specialize in working with trauma, I'm sure a lot of you understand that what that means is that it's very likely that you're also working with addiction. You're working with actually a full range of self-destructive behavior. My books have to do with working with self-destructive behavior in traumatized clients. And so that includes eating disorder behaviors, that includes acts of self-mutilation, that includes any kind of addiction or addictive behavior, frankly, that you can think of. So there's that piece that I think almost always accompanies, to some degree, folks who have chronic histories of trauma, abuse, and neglect, because frankly, they need creative ways to numb, to self-medicate, to try to regulate, because they don't really have good secure attachment in early childhood. Therefore, they don't have good affect regulation skills as they move through life. So I see a tremendous amount of that. And I think you also see a lot of depression, a lot of grief, a lot of anxiety. It manifests as they move through life in terms of struggles with intimacy in their relationships, struggling with trust, struggling in the workplace, struggling with parenting, right? So, when you say that you work with trauma, the sequela of that can really cut across so many different arenas of a person's life. And so I see a lot of stuff. I'm sure you see a lot of stuff as well. What inspired me to create this particular workshop was in part this movement towards trauma-informed care, which again, on the surface, and I am very excited, but I shouldn't just say on the surface, I am really glad that we are constantly reminded to put clients in that historical context to better understand what they're grappling with in their present current realities. But I will tell you that there's not really a universal definition of what trauma-informed care means. And I think that can be a little bit challenging. And so one of the things that I'm going to talk about in the workshop in September is really trying to help to better define what exactly do we mean when we say trauma-informed care. I'm going to tell you what I think it's not. What I think it's not is simply on intake or during the earliest phases of assessment, kind of bombarding the client with a whole lot of personal, intimate questions, such as, were you ever sexually abused in childhood? Were you physically abused? Are you, the victim of domestic violence? Did you grow up with addiction in your family? Not that those are not incredibly important questions to ask, because they are, but the timing, the pacing, when we kind of bombard a client, a new client, with those kinds of very intimate and personal questions has always been of concern to me, because I think just that process of, right out of the gate, kind of throwing very intimate questions at a prospective client is not trauma informed. So I'm going to talk a fair amount about that in the workshop, and looking at things like the pacing and the timing of when we bring that kind of questioning into the process. One of the other things that inspired me to actually create several workshops around this issue was the fact that I had the great privilege of doing a lot of in-service trainings for a very broad range of mental health organizations and agencies. And one of the things that they often complained about was after initial intake. So they would go through a 5 or 6 page intake sort of format with somebody either online or over the phone, occasionally in person. With COVID, obviously, that got altered to a pretty significant degree. But they would go through that intake process. They would get a ton of, again, very personal trauma-based information. They would then assign that client to a worker. And then what they noticed was the client didn't come back. And I don't know if that's something you see, but that's something that was showing up in many, many different places in the mental health community. And so I began to become curious about what's happening there. The client is being very cooperative and compliant. They're answering all of these really intimate and personal questions. They're agreeing to come back for subsequent sessions, and then they don't. And so what I started to do was I started to ask these agencies to show me their intake applications, their intake forms. And I really started to kind of take a close look at the kind of questioning that they were putting out there in these first time connections and interactions with prospective clients. And one of the things that kind of really caught my eye was the fact that this was such intimate information. And then I began to think about the larger context, which is these clients don't know us at all. And so they're coming into a therapeutic situation, probably, with a lot of very legitimate anxiety and concern. They're also coming with their own agenda in terms of what they want to be able to talk about and explore. And there may be a pretty profound disconnect between the agenda that a client brings, the emotional state that they come with where they are in their brains. And I'm going to talk a fair amount about this in the workshop as well, because so much of the time in the earliest stages of therapy, clients are really not in the executive functioning part of their brain, which we call the prefrontal cortex. They're much more likely to be in limbic system because they're sort of in a fight, flight, freeze state. They're guarded, right? And this makes sense. I'm not in any way pathologizing this. To me, this is totally normal. Many trauma survivors come with a mantra that says getting close equals getting hurt. Many trauma survivors come having had their trust betrayed countless times. And so this guardedness, this sort of, let me prepare myself, let me be very hypervigilant, let me scan the room, let me read the micro expressions of the therapist sitting across from me or the intake worker sitting across from me. Let me prepare myself for the possibility of somehow being unsafe. And so because clients come into that process not in the executive functioning part of their brain, but rather in a part of their brain, limbic system, where there's no insight, then it's actually not reasonable to ask prospective clients or new clients to be able to give a coherent, linear narrative about their past and their history when they're actually not in that part of their brain. And so I began to think maybe, just maybe inadvertently, there was this re-traumatization that was taking hold just by virtue of asking these incredibly intimate questions in a way that I don't think is well paced, and frankly, in a way that is premature, given the fact that there's not yet any kind of established relationship. So if we're going to talk about trauma-informed care, the piece that I felt was missing was this notion of trauma-informed intake and trauma-informed assessment. And that has everything to do with having this understanding about where is the client. Some of you may be very familiar with the concept of being in the optimum window of arousal. This is something that people like Dan Siegel and Bessel van der Kolk and Janina Fisher and Pat Ogden have all mentors of mine, have trained us in over and over in the trauma world, that we have to make sure that our clients are able to think and feel at the same time. That's really what we mean by the optimum window of arousal. And if they're not in the optimum window of arousal, and we're then going to bombard them with questions that are not only intimate, but definitely have the potential to be dysregulating and to be triggering, then we're not going to get the answers that we need. And we may create so much dysregulation that clients leave that intake process, leave those first couple of visits where we've thrown a lot of questions because we're trying to get all that data, right, all that information. And they may just come to the conclusion that, you know what? Therapy doesn't feel safe. Therapy is dysregulating. Therapy is overwhelming. I was put in a position where I was asked to respond to questions that I was not ready to answer. I was asked to open the door to talk about parts of my background that I didn't feel safe or comfortable talking about because, again, I don't know the person sitting across from me. So that was really what led me to start to think about this sort of broader idea that it's not just about trauma-informed care as we move through the different phases of treatment, but we really have to think about approaching our clients from this trauma-based perspective in our very first encounters. And I know this might sound obvious to you or simplistic to you, but the honest truth is, at least in the United States, I'm very curious to hear how it is for all of you where you're practicing. This is not something that therapists are encouraged to do. In fact, quite the contrary. Many therapists who work for agencies and for organizations are pressured to get that 6-page intake form filled out, to get as much information about that person's trauma history as possible, as early as possible. And so that, to me, kind of flies in the face of what it would genuinely mean to be trauma-informed. So that's a big part of what I'm going to be focusing on and talking about, and kind of outlining my concerns, and then giving you very concrete strategies about how I think we can do this differently. And truthfully, my overarching intention, every time I give this workshop, I literally just gave it the 3-hour version of this 2 days ago here in the United States. It's not in any way to be judgmental. It's not to shame the therapist. It's frankly to empower the therapist to know that if you've had an intuition or a gut feeling that asking all those questions right out of the gate doesn't sit well with you, doesn't really feel trauma informed, I want to corroborate that. And I want to empower you. And then again, give you concrete ways in which you can do a couple of things. You can slow down the pacing of this work. You can ask questions that are less likely to create dysregulation, less likely to overwhelm and trigger the client, in the earliest stages of the work. And what I'm also going to focus on a lot is what I think we need to be weaving into every single session, particularly those very early sessions when we don't know the client well. We don't know the resourcing that they're coming with. We don't know how well they are or are not connected to a support system. We don't know what they historically have done to navigate feeling dysregulated or overwhelmed. And so until we get that information, I'm going to talk about how we can weave very simple strategies that have to do with breath work, that have to do with going to the body, that have to do with using mirror neurons, that have to do with, again, slowing the work down, giving the client the opportunity to give us feedback about how we're pacing the interview, how we're pacing our questioning, so that we can really work to keep them contained and regulated. So I am going to be giving you some very concrete strategies, because I think it is ethically essential at every single phase of this work that we are taking responsibility for keeping our clients grounded, for keeping them present, for making sure that they're in that optimum window of arousal or tolerance, meaning that they have that ability to think and to feel at the same time. And these are strategies that are simple. They're intentionally simple, because if you've got a dysregulated client, you can't throw something sophisticated or complicated at them. They're not going to be able to synthesize it. They're not going to be able to put it into practice. So very simple strategies to pause the work, to pace the work, to, again, incorporate their body, to help increase their awareness about how am I doing right now? Even really basic things like asking a client after you've asked a probing question, how did that land for you? Let's just take a second and notice what's happening right now on your body. As you answer that question, see if you can check in and notice what's happening for you emotionally. Again, what are you noticing on your body? This is something that I weave into the very first session, because I'm really trying to strengthen the client's ability to be self-aware enough so that they can give me feedback about whether or not I need to slow the work down. And I actually think when we talk about making the work reparative versus re-traumatizing, I want you to consider that when we give a client permission to not answer a question, when we give them permission to put their hand up and say, hang on a second, I'm starting to feel a little bit overwhelmed, right? When we give them the permission to say no or to say stop, that's a reparative moment for a trauma survivor, because that's some of the basic stuff that gets taken from a victim. That is the ability to say no and have it be respected and honored, the ability to say stop and feel like that really got heard. You all know that when somebody is being abused, perpetrators don't stop just because the victim says stop. Perpetrators keep going even when a victim says, no, I don't want you to do that, or I don't want to do that to you. And so these little moments in therapy and in the therapeutic relationship where we're giving the client this very powerful sense of agency and permission to not answer a question, or to say no, or to say stop, or to say, could we slow down for a second, or to notice and give us feedback about how it feels when they answer that question. Those are reparative moments. I'm going to also be talking about how you can help to enhance external safety. And I'm going to talk about how you can do that, whether you're doing in-person therapy or whether you're doing it through teletherapy online. I think, again, there are some very important but very basic things that we can install at the start of every single session that can enhance our client's sense of being present, being grounded, and being safe. So we'll talk about how to track a client's micro expressions, because, so much of the information that we get about how a client is doing in a session is actually going to come to us non-verbally. Now, when you're doing online therapy, it's even more challenging because you get this much of the client. You don't get to see the whole body. So understanding micro expressions, understanding dissociation, understanding a shift in eye gaze, understanding, what happens when you get suddenly constricted, collapsed body posture, that becomes very important information. And we'll talk about how you can navigate that and work with it as opposed to ignoring it. Because for me, that's also information about potential emotional overwhelm, about dysregulation. And it says to me, I have to pause. I have to slow down. Maybe we're opening a door too soon. Maybe the client is really not regulated enough and resourced enough yet to be able to give me that information. When I think about what trauma-informed care means, for me, it's about building a foundation first before I go to the trauma narrative. And I know that feels counterintuitive when we're talking about intake, but I think if you don't have that foundation, and that foundation is giving the clients resources so that they can engage in self-care, so that they know how to recontain, so they know how to pace the work so that they never get overwhelmed. If we don't pour that concrete foundation first, I think that if you're doing trauma retrieval work, if you're getting a lot of information about their history very, very early on, it's sort of like you're building a house on sand. And I want to build a house on concrete. And so that concrete is the foundational work that I think is critically important to do before you do that deeper dive and get that additional information. Now, I want to go on record as saying that I understand that I'm sensitive to the reality that some of you work in agencies where you really feel mandated, like I've got to get these questions answered. And I will address that as well in the workshop. And so, if you kind of feel like your hands are tied behind your back and you have to ask certain questions, even if you intuitively feel like maybe it's premature to go there, that's where what we can then weave into the work, into that session, the self-care, the compassion, the regrounding, so that at least we can try to work towards ending the session with the client kind of regulated again and grounded again. So I'm going to be very respectful of the fact that some of you don't have a choice and you have to ask a lot of questions that might be premature to ask. But, to be honest with you, part of why I give this training in so many different places around the world and so many different practice settings is because I kind of am on a secret mission here. And that mission is to empower enough therapists to sort of rise up and gain confidence about being able to say to their supervisors and being able to say to their executive directors and to their colleagues even, maybe we can revisit how we're doing this, how we're doing intake. Maybe we can revisit the pressure that we're putting both on the therapist and on the client to get information before it really is appropriate and before the client really is in a place where they're able to navigate, the subsequent emotional and cognitive and somatic fallout that will often accompany disclosure. I'm also going to talk about how you can navigate it when a client reveals too much too soon. And I am betting every one of you have had that experience. And I think that that's rooted in a fundamental lack of good boundaries that were never modeled. If you've grown up and you were traumatized in some way, either neglected, where the boundaries were totally disengaged, or the client has grown up with physical or sexual, emotional or verbal abuse, where the boundaries are inappropriate, or they're invasive, or they're enmeshed, it makes sense that they're not coming into the therapeutic relationship with a clear understanding of what healthy boundaries look like and feel like. And so there are clients who are going to come into the therapy process, and in the first 5 minutes, again, you're a total stranger. I know you're all wonderful, and we're all total strangers to our clients, and they just vent everything. Now, in my estimation, that's like a runaway train. And I believe that actually is another reason why many clients kind of unload everything, disclose everything, and then don't come back. And so I am going to talk about what I believe is our ethical responsibility to kind of be the break person, if you will. I never want a therapy session to become or to feel like a runaway train. And I understand a lot of therapists, because I train and teach many, many therapists at my own institute here in Maryland and on the East Coast. And I know that many therapists, are reticent about stopping the client if they do start to engage in a tremendous amount of disclosure, because, you don't want to come across as disrespectful. You don't want to give the client the impression that, you're not interested or that you're not able to emotionally hold or handle what it is that they want to disclose to you. But again, I'm still going to kind of go on record as saying that if it becomes a runaway train and the client discloses way more than is actually appropriate, that's a client who's vulnerable to not coming back. That's a client who's going to sit in the parking lot after a session, or when they click leave meeting, they're going to sit in their bedroom and they're going to regret that they disclosed as much as they did. And so I still think that there are some strategies that we can and should weave into that session so that we can pace the work and slow the work down. One of the metaphors that I use a lot, and I'm sure this is going to make sense to you, and this is actually inspired by Peter Levine's work with somatic experiencing, is we don't want our clients to simply step on the gas and go. Because if you step on the gas and go, inevitably you crash. What I think trauma-informed care actually means is you step on the gas and then you step on the brake, and then you step on the gas again, and then you step on the brake. So there's this toggling back and forth between creating the space so that the client certainly can engage in disclosure, the client can connect with emotion, and then making sure that they don't get to that tipping point of becoming totally overwhelmed or dysregulated. And so that's when we're going to temporarily step on the brakes. And then once we know that they've kind of re-equilibrated and they've regrounded, and their breathing shifts from being quick and shallow to slower and deeper. So now we know we have the activation of the parasympathetic system, which is safe, calm, connected. Okay, now we can step on the gas again. So this toggling back and forth, I think, is really an important dynamic, regardless of the modality that you're using. And I use many different modalities. I am not wedded to just one. And I think, again, being trauma-informed means that you can be spontaneous and flexible, and that at any given moment, you can bring in whatever modality is going to resonate best for the client and be safest and most effective in that moment. So whatever modality you're using, I still think this idea of pacing, toggling, going back and forth, inevitably is going to make the client feel safer and more contained than just simply stepping on the gas, and just letting them go for 30 minutes. Because again, in hindsight, most clients are going to have a fair amount of regret about approaching the session in that way. And now we've unfortunately increased the likelihood that they're not going to come back. And we want them to come back. The other thing that I'm going to talk about in the workshop, again, for me, this all comes under the rubric of trauma-informed care, is we can't just ask questions about trauma. We also have to ask questions about our clients' strengths and their resiliency. One of the things that I feel so committed to as a trauma therapist is wanting to communicate to my clients they are more than their trauma. They're more than their addiction. They're more than whatever it is that has happened to them in life. And again, when I looked at a lot of those intake forms, that was something else that really kind of stood out for me, that there were no questions about the client's attributes, abilities, strengths, positive adjectives that they would use to describe themselves. Because there is this mandate to be trauma informed, it's almost created a kind of tunnel vision in some of the approaches that are being taken now to treatment. And I see this a lot in the agencies where I provide in-service trainings and webinars, where it's just so focused on, let's look at what happened to this person, and therefore let's look at what's wrong with them, and let's look at what their DSM diagnoses are. And there's really no attention that's being paid to all the other stuff that makes up who that human being is, including their strengths. And so I think it's really important when you look at your intake form, if you are using any kind of a formal assessment or an intake form, make sure there are questions about strengths, because that is a way to communicate to the client that you see them as more than their trauma. And again, I think that's incredibly important. The other phenomenon that I'm going to be talking about in the workshop is the idea of rekindling. And rekindling means that oftentimes the way a client presents in our office, the intensity of their emotions, of their negative thinking, of their self-destructive behavioral choices are often not just about their most recent trauma. But what happens is their most recent trauma simultaneously reactivates historical, unprocessed, unmetabolized trauma. So just to give you an incredibly simplistic visual, it's like, let's say the emotion about the current, trauma is this big, but underneath that, there's all this unresolved trauma from the past. And so when they present in our office, rather than looking like, the emotion is this big, it's this big. It's really important to understand that phenomenon, because otherwise the client's not going to totally make sense to you. And you are then vulnerable to giving them a diagnosis that might not be a fair diagnosis, whether it's borderline or another diagnosis that I would consider to be pathologizing. So understanding how past unresolved trauma shows up again in subsequent experiences and the impact that that has on the therapeutic relationship, I think is going to be a really important thing to understand and to talk about. So as we look at all of this stuff, the overarching goals are to help our clients to feel safer in the process, to not push them to give us information that they might not be ready or prepared to give us, to be truly in sync with what their agenda is, particularly in those earliest sessions when they're first summoning the courage, because I do think it takes a tremendous amount of courage to show up for a therapy session. We want to try to reduce the likelihood that that client is going to prematurely drop out of treatment, because then they're not getting the help that they deserve. And again, I want to give you the permission that I think that you deserve, so that you can feel empowered enough in this work that you can pace it in a way that you really genuinely believe is going to be respectful of your client's vulnerabilities. So that's just kind of an overview of what we're going to be talking about and what we're going to be covering. Let me pause here. I am more than happy to answer any questions, any comments that any of you might have, either based on what I've shared or any other questions, comments in terms of the workshop that I'll be giving in September. And by the way, I probably should have said, I am from New York, and so that means I talk fast. I hope I didn't talk too quickly. So if I sped through something and you just need me to kind of slow it down, we are talking about pacing today. So, if I flew through something that you just want me to, reiterate or give you a little bit more depth with, more than happy to do that.
No, it was great. Thanks, Lisa. It was super. I love the idea about giving clients choice. And I think one of the things that we don't do enough of either is give clients a context of why we're doing what we're doing.
Yeah.
Why am I doing this part of the assessment? And why am I doing this part? Because I think people actually don't feel safe unless you give them a context of what we're doing. So I love that. And sorry, you're going to say something?
Yeah, no, I completely agree with you. And, it resonates for me because one of the things I'm constantly teaching the folks that I work with is be transparent as a clinician. When people come with a prior history of trauma, abuse, or neglect, so much of those family dynamics are about a lack of transparency, a lack of honesty, negating and minimizing the child's intuition and perception about what's happening around them. And so it's understandable that when people come into therapy, they're not very trusting. And in fact, they can be quite suspicious. And I never pathologize that. That just makes sense to me given their past experiences. So the more transparent we can be, as you're suggesting, explaining, why I'm asking these questions, why we're going down this particular road, that's definitely going to enhance, I think, the client's sense of safety, both in therapy and within the therapeutic relationship. So yes, I think that's hugely important, that degree of transparency.
Okay, great. So we might bring someone on live. So Robert, okay, could you bring on Wendy, please? Okay. Okay, Wendy, could you turn on your video and unmute yourself, please? I think sometimes what might happen, people might put up the hand by mistake.
Okay. I do see Liam a question in the chat, which I'm happy to go to. Marion asked, could I please develop a bit more about the do's and don'ts regarding dissociation? Yeah, I love that. I think one of the inadvertent mistakes that well-meaning therapists make is that when a client begins to dissociate in therapy, many therapists do not name it. They do not address it. They sort of wait for the client to, kind of reground and come back. I'm a very firm believer in turning that into a moment of psychoeducation and making that a teachable moment. And so I think it's really important to work with the dissociation when it's in the room. You can start by first checking in with the client by asking, would it be okay if I reflected back what I just noticed happened? So along with transparency, the other thing I'm going to add is I ask a lot for permission. And I think there's repair in that, right? Because trauma survivors, nobody asked their permission before they did anything they wanted to do to the victim. So I do ask permission a lot. And so I would ask for permission. Is it okay if I reflect back or share with you what I noticed just happened? Because I'm curious if you have awareness about what just happened. And by the way, when you ask it in that way, typically you pique enough interest and curiosity that normally they say, yes, what just happened? And so I've never had a client say, no, don't give me, don't reflect back. So it's kind of an easy way in. And then I might say something like, I noticed as we were talking that you broke eye contact, that suddenly you were looking all the way off to the side. Is that something that you were aware of? Because sometimes with dissociation, the client is not aware. It can be such a hair trigger thing. A moment of threat that the client experiences, and suddenly they go right to their survival strategy, which is to freeze or to check out. So we want to bring it into their awareness. The thing that I teach my clients about dissociation is it is your superpower. I know that that's how you survived in childhood. I will never take it away from you. I don't have the power to. I don't want to. Here's the thing. I would like for you to feel that you have more choice about when you do and don't zone out. And so if we can talk about the harbingers of dissociation, what did you notice feeling on your body? And I'll share with all of you that there's kind of a universality to many of the harbingers of dissociation that includes a kind of headache, tunnel vision. Suddenly the client feels like you're moving further away from them. They may see your mouth moving, but they don't hear what you're saying anymore. They often describe a kind of darkness that can enshroud them. So the more we can make them cognizant of those physical harbingers, the more I can then teach them that they have the ability to choose. And the ability to choose is illustrated by a very simple cognition, which is name what's happening, right now I'm about to check out. And then ask yourself, this is to the client, ask yourself this question: is it in my best interest in this moment right now? Is it in my best interest to go to the ceiling and check out? Or would I be more empowered and would I have more agency if I stayed grounded and present? And that's the critical distinction that we're trying to teach our clients to make. So if it's showing up in session, I want to use that. I want them to gain deeper knowledge about how does your body let you know that you're about to check out. I also want to make their dissociation contextual. So let's revisit together, what were we just talking about that evoked that need to use the freeze response? You were just answering questions about your dad, or you were just talking about parenting your 5-year-old, right? So making it contextual is important, because dissociation doesn't happen for no reason. Dissociation happens in response to perceived subjective threat. So the more we can help the client to understand what's happening contextually and in terms of the actual content that might be threatening to them, we can slow that work down if we need to. And the more we help them to understand how the physicality of their dissociation, so that then we can kind of weave in that critical moment of choice. Is it in my best interest, or would I be more empowered and have more agency if I stayed grounded and present? And I'm going to talk about in the training that we do in September about some strategies that you can incorporate that can short circuit dissociation. So I'm going to give you a flashback halting protocol, and I'll give you some very simple things that you can do that definitely help to reground the client, get them back in their bodies, get them back in the present. Because as you're describing, Marianne, and I'm glad that you realize it, if we go too fast and if we ask stuff that's too triggering, we're going to wind up with a dissociated client. That's going to happen in the session. So great question. And we will explore that, with more depth in the workshop.
And one of the things, that might be useful to explore as well, Lisa, is that I think one of the feedback we often get is that, especially for maybe subtle dissociation, is that, like, I think what you've been talking about, it's easy enough to spot the runaway train, in our people, because when you think of the words per minute they speak and a lot of movement, so it's easy to see that. But the more kind of subtle dissociation can look like cool, calm, and collected. Someone that, is in a more kind of social place, when in fact they could be kind of dissociating very frequently.
You're exactly right. And that's why, constantly this whole process of getting a lot of feedback from your client, every step of the way, and can they answer those questions? When I ask the question, what are you noticing happening on your body right now? A client who's even subtly dissociative can't answer that question, right? Because they're not in their body. And so knowing the questions to ask that can kind of give you that ability to assess, are they present? Are they in the optimum window? Can they think and feel at the same time? And then knowing what to do if you quickly assess, they're not in the optimum window, right? And I'll definitely share some strategies about what to do to help them to become more present and grounded. We need to have those tools in our toolbox as clinicians, for sure. Super. I see in the chat, I see that Sonia asked, do these principles apply intake with parents of children coming to child psychotherapy, play therapy? I say yes. I say that I want to be just as sensitive to the pacing and the timing of when I'm asking a child questions, or the invitations that I, am bringing to the work, whether it's through, play therapy or other modalities. I think that it holds just as true for a child as it does for a teenager or for an adult. And I will share with all of you that although I don't work with young children anymore, I do Santre, I do drawing, I do, I work with the body, I use music. So a lot of the modalities that I think are great when you work with young children, I do all that stuff with adults, because I do a lot of parts work, and I have a lot of clients, where we're working on their inner child. And so, yes, it's very applicable. It's very applicable. And I would take that same, slow pace approach with a child, maybe even slower, frankly, with a child, than with an adult, because the child is coming with a whole additional set of anxiety and curiosity, yes, which is a great thing that we can tap into, but also anxiety. You know, what's going to happen here, and what is this person going to ask of me, especially if that child has a fairly recent history of being in some way betrayed by an adult authority figure. You know, they're bringing that traumatic transference with them into therapy, just as an adult is.
Super. So we have two questions in the Q&A. So okay. The first is from Dr. Anne Long. So please, Lisa, could you share some techniques to slow people down when they present like the runaway train? Thank you.
Yeah. Again, I don't want to give too much away today because I'm going to be talking a lot about it in the workshop. But I'll just tell you very simply, one of the most effective things is remembering to tell your clients to pause and breathe. You know, trauma survivors are, I know this might sound strange, but trauma survivors are not good at breathing in a way that is most beneficial to our bodies. And what I mean by that is when we are in a fight, flight, freeze state, we do this. We breathe in and we breath hold. And if you have for years and years and years of your life needed to live in this sort of state of hypervigilance and high alert, it's far more likely that you breathe in and kind of breath hold and don't fully exhale. And so when we see that it's starting to become a runaway train in the session, if I go like this, that's the universal signal for stop. Right? And Virginia Satir talks about how we attend to nonverbal cues way faster than verbal cues. So the very first thing that I'm going to do is I'm going to put my hand up. And you're going to react to that more quickly than if I used words. Now, once I do that, I'm then going to say, let's pause. I don't say stop. I think stop is too abrupt. And I don't want to come across in any ways disrespectful. But I will say, let's pause. Let's take a breath together. Now, if you've got somebody who is hyper aroused and they're at the top end of that window, know that they're not going to be able to take a slow, deep breath in. So what I'm going to do instead is what's called stair step breathing. Little quick inhalations, which really respects the fact that they're at a place physiologically and somatically where they're already doing very quick, shallow breathing. So stair step breathing are slow little inhalations. And then, so that's stair step up and then escalator down. Long, slow exhalation. I'm going to demonstrate it. It looks like this. You just take as many inhalations as you get to the top of your breath. And then it's a long, slow exhalation down. That what I'm really targeting is the long, slow exhalation down, because the exhale is what activates the parasympathetic system. Inhale activates the sympathetic system, which is fight, flight, freeze. Exhale is the parasympathetic. So if it's a runaway train, I'm going to put my hand up. I'm going to say, let's pause. Let's take a breath together. I'm going to show you how to do it. This is what I'm saying to the client. I'm going to show you how to breathe in a way that's going to help to just slow down and calm down your physiology. Because again, my ethical responsibility to you is to make sure that you stay safe in this entire session. That's the transparent part. I'm explaining why I'm putting up my hand, and then I'm going to demonstrate that stair step in and that escalator down. It's a very specific piece of breath work that you use when the client is hyper aroused and agitated.
Okay, super. And the next question is from Grace. I recently, excuse me, had a former client contact me with feedback that the work we had done to access and resource the body during therapy was actually traumatizing them as someone who now identifies as on the autism spectrum. And then in brackets, though during the sessions, it looked like it was useful and grounding.
Yeah. The first thing I want to say to the therapist is, I know that you had nothing but great intentions, and we have to be really careful, when we get that feedback, to not beat ourselves up. We are not mind readers. And sometimes clients can look, and Liam, alluded to this. Sometimes clients can look like they're fine, and they are coming across as cooperative, and they're not giving us any feedback in the session. And we can't know, you're not in someone else's body, and you're not in their head. And definitely we've all had that experience where we think it's going along swimmingly, and then subsequently we get feedback that they were drowning. And they gave us no outward indication of that. So I just want to normalize that for you, that happens to the best of us in this field. This is where I think, again, this idea of weaving into the session more moments of feedback is one way that you can reduce the likelihood of that unfolding in the way that it did. And I just think that we sometimes forget to do that. We get focused on the intervention, we get focused on the strategy, and we're often running, and we may not be taking the time, enough of the time, to keep checking in to see how is this really landing for the client. And if you were to take a survey of my clients, they'll tell you one of the things that I say countless times in a session is, how is it landing? How is it landing on your body? What are the thoughts? What's the imagery? Where are you holding emotionally right now? 1 to 10, how activated are you feeling? Because if you don't do that checking in, you can spend the whole session thinking everything was fine, and then get the feedback after the fact. Now, the way that I would handle that with that client, first, I would let them know that you are so grateful for the courage that it took for them to give you that honest feedback. To me, that's a reparative moment for the client, that they're being honest. They're not just being compliant or acquiescent, as so many trauma survivors tend to be. The fact that this person summoned the courage to be honest with you and to let you know the effect that session had, you really want to commend them. You want to say to them, this is the courageous part of you. And I want to encourage you to not wait until the session is over as we move forward together, but we're going to build in strategies now that are going to give you the opportunity to give me that feedback throughout the session, so that we can both attend to your safety.
Okay, super. Lisa, unfortunately, we're out of time.
Okay. I know I could do this for 12 hours, but the good news is we're going to meet again in September.
Yeah, that's great. We're going to be back on the 9th of September. And I think Mary has very kindly put that discount coupon up on the chat again. So if anybody's interested in signing up, it expires in 24 hours. And just a big thank you, Lisa. And just before we go, just big thank you to Mary and Robert that were in the background keeping everything going. Thanks, guys. And Lisa, I'm really looking forward to September.
Me too. Thank you all. Such a pleasure to be with you. And I look forward to seeing you all again. Above all else, I always end the same way, which is take good care of you. You are only as effective professionally as the extent to which you take care of yourselves personally. So take good care of yourselves.
Listen, bye.
Be well.
I look forward to seeing everyone soon. Bye.